Now let's look at acute infectious cystitis, which is inflammation of the urinary bladder. Symptoms include suprapubic pain, dysuria, urinary frequency and urgency. Systemic signs are absent in this case because it's a localized condition. The risk factors are being female, unfortunately, because it's easier to get infections in the bladder for women due to the shorter urethra. Sexual intercourse, which can introduce bacteria into the urethra, leading to infection of the bladder. Indwelling catheters in the urethra, which make it easier for bacteria to colonize the bladder. And the most common causes of acute infectious cystitis include Escherichia coli. Then there's Staphylococcus saprophyticus in sexually active young women. Klebsiella, Proteus mirabilis, which causes the urine to have the scent of ammonia. This is one of those urease-producing bacteria, and that leads to which type of kidney stone that we talked about. The answer is the staghorn calculi. Remember that urease breaks down urea into ammonia, making the urine more alkaline, and that can lead to staghorn calculi formation. Of course, that's in the kidneys, and here we're talking about in the bladders. Now, what would you use to treat an infection with Proteus mirabilis? Fluoroquinolones. There's also adenoviruses, which can cause hemorrhagic cystitis. And lab findings with a patient with acute infectious cystitis will include a positive leukocyte esterase due to the presence of white blood cells in the urine. Urine nitrites will be present with gram-negative organisms like E. coli. And finally, patients will have sterile pyuria, and negative urine cultures may indicate an infection with Neisseria gonorrhea or Chlamydia trachomatis, because both of these organisms are intracellular. And that's why the urine will look like it's sterile and the patient is having pyuria, but actually the organisms are inside the white blood cells. So the next topic to discuss is infection of the kidney, which is called pyelonephritis. In the acute setting, it's typically caused by a UTI, urinary tract infection, that spreads up the ureters and into the tubular system of the kidney, sparing the glomeruli and vessels. So it spares the glomeruli and vessels, but it is affecting the cortex of the kidney. Now, before we jump into symptoms, notice in this picture the large infiltration of neutrophils. These neutrophils are the acute responders to the bacterial infection. And all this neutrophil infiltration and bacterial infection leads to a lot of damage of the kidney and to the symptoms. So the symptoms are going to include dysuria, fever, costovertebral angle tenderness, nausea, and vomiting. The first time you see a patient with this, you will never forget it, because tapping on their costovertebral angle will make them jump right off the table because it's so sensitive. And causes of pyelonephritis include ascending UTIs, vesicoureteral reflux, because that makes the patient much more prone to getting bacterial infections ascending up to the kidneys. And how else could the pathogens reach the kidney? Through the blood. Hematogenous spread through the blood to the kidney. Risk factors include indwelling urinary catheters, urinary tract obstruction, because less urine flow makes it easier for bacteria to move up the ureters because they're not being washed away with urine. Diabetes mellitus, they have a weaker immune system and more prone to infection. And pregnancy. Complications include chronic pyelonephritis, renal papillary necrosis, and perinephric abscesses. Treatment is obviously antibiotics to cure the infection. So we talked about acute pyelonephritis. Let's now talk about chronic pyelonephritis, which doesn't happen unless there is some anatomical abnormality that causes the patient to have multiple cases of acute pyelonephritis. This anatomical abnormality predisposes the patient to repeated infection. And it can include things like vesicoureteral reflux, which allows bacteria to ascend up through the ureters to the kidney, and chronic kidney stone obstruction, which prevents urine from washing out the bacteria and allows the bacteria to move up to the kidney. What happens in chronic pyelonephritis is that there is repeated infection of the kidney, which leads to infiltration of the kidneys by lymphocytes. And you'll see white blood cell casts in the urine. And because of this repeated infection and inflammation and infiltration of white blood cells, the kidney gets scarred. And this corticomedullary scarring leads the kidney to become a fibrotic mass rather than the normal parenchyma of glomeruli and tubules and blood vessels that you would normally see. So on CT scan, you'll see blunted calyces due to the scarring of the tissue. And the kidney will begin to look like thyroid tissue under the microscope due to eosinophilic casts. Eosinophilic casts. So we talked about pyelonephritis, which is an infectious cause of inflammation in the kidneys, but now let's look at a non-infectious cause that can damage the kidney. The first one that we have is drug-induced interstitial nephritis, also known as tubulointerstitial nephritis. Now, just like the name says, patients have white blood cell infiltration into the spaces in between the tubules. The word tubulointerstitial means it's interstitial between the tubules, meaning interstitial space between the tubules. So, usually, there is pyuria in these patients, meaning there's white blood cells in their urine. But can you guess which type of white blood cell we're going to have? The answer is eosinophils, because it's a hypersensitivity reaction to drugs, and the responders are eosinophils. There's also azotemia as the renal function declines. The hypersensitivity to the drugs usually results 1 to 2 weeks after taking the drugs, and the drugs are acting as haptens. Because they're acting as haptens, they are making certain proteins in the body immunoreactive, and antibodies are recognizing them, and it's leading to inflammation. Now, the drugs that can haptenate proteins and lead to this drug-induced interstitial nephritis include things like diuretics, penicillins, sulfonamides, and rifampin. NSAIDs can also cause a hypersensitivity reaction even months after taking them, so not necessarily just 1 to 2 weeks after taking them. Symptoms include fever, rash, hematuria, CVA tenderness, and sometimes the disease can even be asymptomatic. And it's a critical part of treatment to remove the drug. Stop the drug that's causing the tubulointerstitial nephritis. That's the first thing you have to do. Okay, flash quiz. What finding on urinalysis would suggest pyelonephritis in a febrile patient with flank tenderness? The answer is white blood cell casts. Remember what we said. White blood cells will only form casts in the tubules. If there is an infection in the kidney and the cells are able to get into the tubules, and then urine will push them out and they'll come out as a cast of the tubule in the urine. And so the infection has to be in the kidney. Otherwise, an infection in the collecting system could lead to white blood cells in the urine, and this is referred to as pyuria, but they would not be molded into the cast-like shape of the renal tubules. And so the good suggestion that the patient has pyelonephritis is the white blood cell cast.